It may seem obvious that in any clinical PDT treatment, we want to maximise the effect, whilst also minimising any adverse events. And as we've just heard, to do that, we need to understand the underlying treatment mechanism. And we need to know the variables which affect PDT outcome. Now, in order to know the variables, we need to be able to measure the variables. So Lord Kelvin said, when you can measure what you're speaking about and express it in numbers, then you know something about it. And dosimetry is the science of this measurement. In this particular instance, it's the measurement of the variables which can affect PDT outcome. We know the three major components for PDT treatment: the light, photosensitizer, and oxygen. But within each of these components, there are variables which can affect the treatment outcome. And for decades now, techniques have been developed in order to measure these different variables, but few have made it beyond the research stage, and even less into routine clinical practice. And maybe this is where the problem lies. If we don't monitor these variables, then the chances are we can end up with inconsistent treatment results. However, if the techniques are so complex and difficult that they can't be practically implemented, then again there might be some reluctance in using the PDT technique routinely. It's a bit of a damned if we do, damned if we don't situation. But what if there was an alternative? What if we could use a single measure, something that was already clinically accepted, in order to predict treatment outcome? And that's a thought that I'd like to explore at the end of this presentation, but just now I want to go into the different variables which can affect PDT treatment. As we've just been hearing, when a photon activates the photosensitizer in the presence of oxygen, we get reactive oxygen species, which in turn results in oxidative damage. And therefore it makes sense to look at all of the variables which affect this oxidative damage. And this is the approach that's taken by the American Association of Physicists in Medicine in their report 88 on photodynamic therapy dosimetry. They define the term R threshold, which is the threshold value of oxidizing events that's required to cause cell death. And the way we define R depends on the thickness of the tumour. So two scenarios are considered in the report: thin superficial lesions at less than 100 microns, and then thicker tumours. For thin lesions, such as actinic keratosis as used in skin PDT, we don't need to worry about light penetration in the skin. We can assume that the light is uniformly distributed throughout the tumour. However, that's not the case for the thicker tumours. But if we start with the thin superficial lesions, then this threshold value can be defined by the equation shown here. Now this looks horrible, but actually we can break it down a wee bit. Okay? We can break it into the three components that we saw earlier. The parameters which are light related, those which are photosensitizer related, and finally those that are related to photobiological parameters, which are generally related to oxygen. If we start with the photobiological parameters, the phi represents the efficiency with which activated drug is converted into oxidized radicals. And that generally depends on the concentration of oxygen in the cell. Once those oxidized radicals have been created, F represents the fraction of those that actually target the sensitive site, because there will be some which target non-sensitive sites. Now, these parameters are not well known. They are difficult to measure, and in routine practice, they're not monitored. And they can vary quite a bit. For example, we've just been hearing that if the treatment rate is too high, if the light is too strong and the concentration of the drug is too strong, then actually all of that oxygen can be used up very quickly in the treatment. For the photosensitizer parameter D, that's the concentration of photosensitive drug actually in the target lesion, so not what's administered, but what actually gets to the lesion. And this can be measured with both absorbance and fluorescence techniques. But again, is not actually routinely done. There is some recent research suggesting that actually if we take a measurement prior to treatment, a fluorescence measurement prior to treatment, that this may be predictive of treatment outcome. And the professor has just been speaking about photo bleaching as well for monitoring during treatment. This would obviously be a great step forward if you could predict what the treatment outcome would be before we actually perform the treatment. And then there are the light-related parameters. These are generally much better known. Almost all PBT treatments will monitor the exposure time. That's nice and straightforward to do, with the possible exception of daylight PBT. And in general, the irradiance is well monitored as well, although there are varying degrees of accuracy to which that's performed. The backscatter from underlying tissue, this isn't routinely measured and can vary greatly as well. Published reports suggest up to a factor of 4 for this parameter. And then if we look at the final variable there, the extinction coefficient, that's related to the wavelength absorption of the photosensitizer. Now in theory, if you choose a wavelength at which there is high absorption, then you can get away with a lower irradiance than if you take a wavelength which has a lower absorption. However, this of course doesn't take into account depth penetration issues. So the equation, if all of these variables were consistent between patients, or if they didn't change during treatment, then we wouldn't have to monitor them. It would be much more straightforward. But in reality, they do vary during treatment, and they can vary quite a bit as well. And by not monitoring them, maybe we're introducing variability into the treatment. Maybe it's causing some confusion in the literature sometimes. And maybe one of these variables might be responsible for treatment failures. So whereas with the thin lesions, we didn't have to worry about light penetration into the tumour, for the thicker lesions, this isn't the case. And the expressions are very similar, apart from we replace E, the irradiance, and K, the backscatter, with the fluence rate. Now, fluence rate and irradiance have the same units, it's both watts per metre squared. But one, irradiance is defined as surface illumination, whereas fluence rate is illumination over a sphere. They can be the same, or they can actually differ by a factor of 4. It depends on the illumination scenario. Now, as light penetrates into the tumour, it will be absorbed and it will be scattered, so there will be a maximum depth at which you can still get necrosis based on the light penetration. And this is how this report 88 defines these values. Again, we have the equation on the top for the threshold value of oxidizing events, and the one underneath represents the fluence rate. Now, this maximum depth of necrosis, Z, is defined in the equation here, and with a little bit more horrible looking maths, you can substitute in the equations rearrange, and come up with a value, how Z is represented. And again, although this looks horrible, it's actually incredibly useful, because what it tells us is that Z primarily depends on delta, which is the optical penetration depth of the light. In other words, it's the wavelength of light. If any of these other parameters in the equation change, they have to change by 7.4 times just in order to double the Z value. And that's because of the natural logarithm that's in front of them there. So this explains why we search for photosensitizers that can absorb at longer wavelengths in the so-called near-infrared optical window. So all of the equations that I've talked about before are all relevant for parallel beam illumination, but the same can be done for both spherical and cylindrical beams as well, and just need some slight adjustments to the equations as we show here. So PDT dosimetry is incredibly complex, and despite the fact that there have been techniques developed over the years, very few have made it into routine clinical practice. Now, in this topical review by Brian Hogue, they suggest that the complexity of these techniques is the reason why PDT hasn't been as successful as it should be. They suggest that in early preclinical research and in phase 1 trials, that we should measure as closely as possible all the variables which affect treatment outcome and determine which one has the biggest impact. And then once we know which one that has the biggest impact, in phase 2 and 3 trials, we should then look for a surrogate measure, something which is already well understood, something that's clinically acceptable, maybe something like CT imaging or some blood marker, something like that. And we should determine that surrogate dependent on what variable has the largest impact. They say that this would work out the nice compromise between not monitoring at all the variables and the complexity of measurement as well. And it would be great if these surrogates could also be predictive of treatment as well. So if they could be performed prior to treatment, they could predict what treatment would be. It's a very complex picture, PDT dosimetry, and hopefully over the past 10 minutes or so, I've been able to give you a very brief underlying view of what's involved. So thank you very much for your time, and thank you for listening.